Okay, the first thing for the hip flexion. I would ask my patient to bend the less affected side. So she bent this, right? How to use the associated reactions here to get that limb flex? Extension of the other limb, right? Okay. So what if I ask her to push down here on that heel? No, on that heel, push down there. So what would be the response here? Flexion, right? Can I assist that? Yes. Sometimes, okay, the quad's spasticity is going to block that movement. Okay, so okay, so I would ask my patient to push down, which is extension at the head, facilitating the flexors on that side. Okay, at this stage, we just needed like less than 90 degrees. So my hand is going to support the limb. As also the stage said, it may happen with abduction and external rotation. They said, okay, allow that, okay? But I'm gonna work to prevent it, actually. So my hand is going to support and bend the knee a little bit. And ask my patient, just push down on the other heel and pull this up. So she's going there, okay? And you repeat that again. Okay, what if this doesn't work?
Ticklish.
Okay, what if this doesn't work? That would be good. She would do the next one very good. Vein template. Okay, so if this does not work, what did you say? Okay, so if this is not working, okay, I just want to add another stimulus, okay, or another facilitation method for this. Okay, so do you remember last time when we said we can apply some pressure there, right? So again, my hand here, ask my patient to push on that heel down, okay, apply pressure there, and then the movement would go up there. Okay, my hand again is preventing that external rotation. What if this does not work?
I have a question. How does applying pressure to the great toe facilitate?
Not in the great toe. I'm applying the pressure at the first rib space here.
Dorsal space?
Yeah. This space here. This, you guys know the extensor plantar response to the Babinski, correct? You know that. So Babinski, there are more than 11 methods to do that, to facilitate this. So this is one of them, okay? And applying this pressure, or part of the Babinski, or the plantar response, is dorsiflexion, knee flexion, hip flexion. So it's a mass flexion. Okay? So if the pressure does not apply here, okay, I can apply it here. So here is the Achilles tendon. Okay, so Achilles tendon here, right? Just go and pinch it. Okay? But when you pinch, my intention is not to hurt, just like to get the muscle facilitated. Okay, I want to apply another thing. This is not working still. Okay, so I would have my patient a little bit to the side of to the edge of the table. Okay, more. Thank you. And have this leg out of the table like here. So you think with me, what is adding here to this muscle, to this group of muscle?
Stretch.
Stretch, right? So stretching would add more firing to the muscle, right? So now I would have this leg bent, associated reactions. I would have a stretch on the I would have a stretch on the hip flexors there as iliopsoas. I'm talking about the iliopsoas. And a stretch when you bend the knee here, a stretch on the rectus femoris. Right? So now if I go and apply the same pressure there, okay, the response would be going up this way. Okay? So applying the pressure again, she's going up. Okay? This would be the response. Good. Is that a voluntary movement? No. It's not yet. So now what's gonna happen? Okay. So I would ask my patient to do this and repeat the stimuli. And then now would ask her to start doing the movement by herself. Okay. So lift it up. So my patient may lift up to here. I can continue for them. Continue to complete the range and go back down again. Ask her to do it. Once you got the movement going, and this would not be hard. Second or third visit, you would observe that she got a hip flexion. A good one. Am I done here? Not yet. So my next step is to have her lower the leg down. What type of contraction is that? Eccentric contraction. Okay? And now I would ask her to lower down and hold it in the middle. Lower down, hold it in the middle, lower down. So a mix between the eccentric and the isometric. And all of this against the weight of the limb. Correct? So now she's lifting her leg, so there is some resistance. Lowering down, there is some resistance there too. Okay? Now, let's go back, having the leg on the table. And would ask her to straighten up this leg. So no associated reactions anymore, no stretch anymore. So ask my patient again to do the same movement going into flexion. So it's a complete voluntary movement. No associated reactions, right? No stretch applied to the muscles to increase the firing. And she is in supine. Okay? Before we move to the next step, I would start applying resistance to the flexion of the head. So bend, please. So here is the flexion, okay, against the resistance. And again, flexion against the resistance. Now my patient can do that in supine very well. Before moving, to the next step, now she is passing stage 3. So I will do that till the end of stage 3. Okay? Once she's done, she is passing stage 3, means that now she can do that against gravity. Okay? But not in sitting. We move to standing without going through sitting, right? Because this movement would be force limited by the trunk. Okay? So I would ask her to stand up, please. Oops. Okay. Having her kind of having safe environment. Okay. I'm gonna be in front of her. Okay. She is here. Okay. With the less affected side holding on the table, so she's safe, right? Okay? And then starting asking her to lift the leg up. She may be able to do that as she did here. Enough. As a start. Okay? And as you continue doing the exercise, she should be able to reach here. Should we kind of going up there? How many degrees do you need for the hip flexor during walking? 30. So that's 30. Not even 90. But you got 90, that's great. You may need that for other activities, like stepping up, something. But for walking, 30 degrees are required. This is the maximum of the hip flexion during walking. If the patient is doing this, okay, remember? So here, look at her left hand. Why is there?
What, the middle picture?
The 1, 2, 3, the third, and even the fourth still there. Why hand is here? Why is that? To prevent hiking. The hip hiking. Why? The QL muscle is always active muscle.
Oh yeah.
Right? He knows now. The QL would be going this way. So remember the circumduction gait? When you go back to the lab PowerPoints of neuromuscular one, the first line, it says weak hip flexors. Okay? So if your patient continues to activate the QL muscle, I may have them sitting, okay, on the edge of the table like that. Lower it down a little bit. Okay, like half sitting there, okay, and start lifting the leg up. This will prevent the QL from being active there. Your patient will be able to do pages number 4, number 5, number 6, okay? They're at the stages of 4, 5, and 6, maybe 7 there. See here, the patient have a free ankle weight here. See that? Right? Okay, it's kind of resistance to the movement. Right? And if you have staircase at your workplace, having the patient standing on the less affected side, having the weight there, and move the leg to touch the first step, which could be 6 inches. The second step, so they lift up, so 12 inches. Okay? Usually those with the staircases, they may have the 8 inches. Sometimes they have the 8 inches too. So lifting up to the 8 inches, okay, against the weight, right? Okay? And if you wanna give them the second step, it's gonna be 16 inches, that would be the leg, right? It's too high. So I would prefer the 6 inches. These are the standard, okay? This is the height of any step at home, 6 inches. So 6 and followed by 6, okay? If or in case you have a high step at anywhere. Okay? So for the hip flexors, we start from the beginning when we use the associated actions, when we use the stretch for the patient, okay? When we use the activation methods of the muscles, the reflex, right? Moving to resisted hip flexion, okay? Then in standing, where they would be task specific. Okay? These exercises starting at this third picture, all of them are task specific training. But now I'm sure that the patient can isolate the movement, even against the gravity, because the gravity would increase the tone. Okay? But I want my patient early in supine lying position to avoid the effect of gravity, okay? To have more stimuli to the movement. Okay? I used many of them to just give that muscle a push to move. Okay? So that progression, for me, it makes a lot of sense. But from the first day after stroke, have the patient sitting on a wheelchair. This is very common. Sniff in acute settings and subacute settings, and asking the patient to just start lifting up. It's not task specific. The patient is not able to do it. It's nothing. Okay? Questions about the hip flexors?
Did you ever use any tactile stimulation for this?
Having your hand there, it's kind of on the feet, but to reach to the flexors here, it's kind of really, it's not that easy, right? Okay. Questions? Comments on the hip flexors?
Is pinching the Achilles more, is it a reflex or is it
All
because
of them.
it's painful?
All of them are
it's a
reflexes, yes. Okay? Do you guys do that?
Yeah.
Good.
Yeah, I don't like the, that's what you said is a pet peeve of mine.
Do it?
The PTs just do that.
Yeah? Okay. So you really need to do the progression. Nothing is going to stay at one point. Start with very easy. Use whatever you can use to activate the muscles, okay? And then you move forward as your patient progresses. Okay, what's the next group? What do you think? The abduction?